Hi, this is Andrea Kane, and I'm here with HIT 292, Healthcare Reimbursement. Sorry, I gotta spit that out there. Healthcare Reimbursement. We are on still week 11. This is lecture video number 5 of 6, and we are moving forward now with Medicare and Medicaid prospective payment systems for post-acute care, specifically looking at inpatient rehab facilities. As I've said in the other videos, you can check your syllabus for unit objectives. If you're following along in your book, please turn to page 209. We're starting at the very bottom of that page to go forward. So inpatient rehab facilities, how about them? Yes, they have a prospective payment system. We're going to talk about the specialized collection instruments that exist. Last video that we did was on LTACs. And they use the care system. Now we're moving on to inpatient rehab, and we'll find out what they use as their collection instrument. Then we're going to talk about the classification models, payment formulae associated with reimbursement under Medicare and Medicare PPS as it looks at post-acute care. These are key terms. And again, in your book, these are the ones that are kind of a blue-purple. Not sure if you'd call them lilac. Maybe. Every time I move my book around, it seems like the color of them changes a bit. But they're in the glossary in the back that you can look up too as well, starting in page 307 in the glossary. So if you're interested, you could take a look at those. But anyway, inpatient rehab facilities, what do? They provide intense multidisciplinary services to inpatients. I have a friend whose daughter was recently in a very traumatic accident. She and her fiance were walking down a sidewalk, and two cars were driving down a road. Speed limit 35 miles per hour. They were both going 70, doing some street racing. Neither one had a driver's license, and they were both borrowing cars from other people. And the one closest to the sidewalk unfortunately lost control and hit them from behind and threw them both 80 feet in the air. As you can imagine, they had traumatic injuries. And as you can imagine, after several days and several surgeries and plenty of intensive care unit care, they ended up in an inpatient rehab facility. Thankfully, they are both doing fine. They're planning their wedding for December. So lots of Thanksgiving for all of that. But talking about inpatient rehab facilities, they typically take patients directly from an inpatient acute care hospital. They're not one that takes the patient in, stabilizes them, and then starts working with them. They take patients that are now ready for intensive rehab. They've gone through an acute care hospital stay, and they're there for intensive rehab. So they're typically receiving patients as a transfer from that type of perspective. So they receive patients a lot of times that have had strokes, that have had injuries, that need inpatient level nursing care in addition to their rehab. And so usually a physiatrist or the medical director of the rehab facility goes to the hospital, consults with the attending physicians and surgeons and the patient and their family, and identifies that yes, they meet an inpatient rehab facility is what's going to meet their needs, and they arrange for that transfer. And they can handle patients that need inpatient level of care, but in a rehab setting. So that's what that is. That's why it's different than an outpatient rehab facility. Let's see what else they want us to cover here. IRFs are licensed under state law. So it varies state to state. There are freestanding inpatient rehab facilities. That's the most common. There are some inpatient rehab units in hospitals. You may find those, but most commonly we're talking about separate, freestanding, independent inpatient rehab facilities. when the things that are excluded from IRF PPS are VA hospitals, hospitals reimbursed under state cost control systems or authorized demonstration projects, or non-participating hospitals that furnish emergency medical services to Medicare beneficiaries. If a rehab facility falls under any of those three, or a rehab unit, it will not qualify for IRF PPS. So just keep that in mind. Also, it says to be classified as an IRF under IRF PPS, a facility must meet a compliance percentage. That's the minimum percentage of an IRF's inpatients requiring intensive rehab services in one of the qualifying conditions, including comorbidities. And it's a 60% rule. And this is on page 210 in your book, in case you wanted to take a look at that. Also on page 210 are the 13 conditions qualifying for designation as inpatient rehab facility. These are the 13 condition types that would make a patient meet, or a facility, they provide services for these. So you might want to take a look at that. That's figure 8.7. The Balanced Budget Act of 1997 is what kicked off inpatient rehab facility PPS, and that's also in your book. It was also addressed in the Balanced Budget Refinement Act of 1999 and in the Medicare, Medicaid, and S-CHIP Benefits Improvement and Protection Act of 2000. It wasn't until January of 2002 that IRF PPS actually officially started with the facilities. The checks actually went out the door and all of that came into being. Everything before that was refining the system, creating it and refining it. Medicare beneficiaries' inpatient rehab hospitalizations are covered under Part A Medicare. And a pre-admission screening establishes a Medicare beneficiary's eligibility for inpatient rehabilitation. So in order to be eligible for treatment in an IRF, the beneficiary must be able to tolerate and benefit from 3 hours of therapy per day or 15 hours per week, 7 consecutive days. Medicare beneficiaries admitted directly from an acute care inpatient hospital do not pay a second inpatient deductible because the IRF admission is part of the benefit period. However, Medicare beneficiaries who are admitted from the community are beginning their benefit period, and thus they have to pay an inpatient deductible. So be aware of that. Looking at the screen, inpatient rehab facilities use a case rate methodology. All services are included in one payment for the admission. And I guess I got a little behind on my screen here, sorry. And this was the 60% rule, and here are the qualifying conditions. And all of this is on page 210 in your book. And this is what I was just talking about. In order for Medicare to pay for an IRF admission, they have to be able to tolerate the rehab. Their admission has to be reasonable and medically necessary. You've got to have a doctor's order for it. You've got to be examined by a physician and have an order for it. And then you have to submit the required coverage criteria documentation to CMS within their timeframes. And of course, as we talk through all of this, we talk a lot about Medicare and Medicaid, but essentially the third-party payers, it's very similar with them. All the third-party payers have their own rules that usually dovetail with what CMS does. So even though we focus with talking about prospective payment, because that's Medicare and Medicaid, which is the primary bulk of most patients being admitted to whatever setting you want to talk about, third-party payers are also still very much in play, and those have to be researched sometimes individually to know what their rules are. And then, of course, self-pay is exactly what it is. There are no rules with self-pay, simply that the patient or their family must be able to pay for the care that they receive. So I wanted to just stop and mention that because we focus on it, but really we're not meaning to slight the others. It's just that third-party payers tend to follow a lot of things with the federal government, and the federal government is the biggest bulk of payers or player. It's the biggest payer when you talk about case mix, or I'm sorry, yeah, when you talk about your um, mix of payers, payer mix. That's what I was trying to get to. Sorry. All right, so what is IRF's patient assessment instrument? Is it MDS? No, that is skilled nursing. Is it CARE? No, that is LTAC. Is it OASIS? No, that's home health. So what is it? It's PAI, Patient Assessment Instrument. So anytime you see PAI, think inpatient rehab. It's completed twice for each Part A and Part C patient on admission and at discharge. It requires lots and lots of patient information, including payer, medical, functional, independence, therapy, and quality indicators. And this is all on page 211 in your book. And yes, we kind of then move over a little bit into page 212 in case you're wondering about that. So what is all in the PAI? How do you assign codes? Well, first of all, you've got to have a reason for admission. And you've got to have an impairment group code, and that code needs to be unique to inpatient rehab. According to your book, by the fourth day of inpatient admission, the IRF PPS requires assignment of codes. These codes reflect the reason for admission to the rehab facility using impairment group codes, the etiology of the impairment using ICD-10 CM codes, comorbidities and complications using ICD-10 CM codes, and the reason for interruption, transfer, or death, and that would be obviously discharge, using an ICD-10 CM code. So ICD-10 CM pretty much rules, but you do have reason for admission codes as well from the impairment group. And etiology is just what it sounds like. It's why is the patient requiring inpatient rehab facility services? And then complications, comorbidity, same. What is making their stay require an intensity of services? What is the severity of illness causing intensity of services? And then there is a functional independence assessment. That's an 18 item, not TM, item, 18 item instrument that reflects patient characteristics and captures their functional status, their ability to perform their ADLs. If you look at your book, on page 213, there is figure 8.9, and that gives you the functional independence measure, or FIM. Again, anytime you hear FIM, you want to be thinking IRF PPS. And so, for example, for motor items, it talks about eating, grooming, bathing, dressing the upper part of the body, dressing the lower part of the body, toileting, bladder control, bowel control, bed chair, wheelchair transfer, toilet transfer, tub shower transfer, although CMS excludes that, walk wheelchair locomotion, stairs locomotion, and then cognitive items are comprehension, expression, social interaction, problem solving, and memory. Before we get to standard of payment, I don't know why or structure of payment, before we skip on to that, I really like table 8.8 at the bottom of page 213. Take a look at that if you would. That table talks about the time frames for completing the IRF PAI. Please make sure you are familiar with these. That days 1 through 3 are the observation period. Day 3, is either the date of discharge or discontinuation of covered services or So the event is observation period. The observation period is days 1 through 3 for admission, or the day of discharge or end of Medicare Part A fee-for-service coverage if you're talking discharge. The assessment reference date is day 3 at admission, or the date of discharge or discontinuation of covered services. completion date is day 4 for admission. So on day 4, it has to be completed. If you're talking about discharge, it has to be completed by day 5 following discharge or discontinuation of covered services. Encoded date, that's day 10 after admission or day 7 following completion date. So completion day would start as day 1, so you have 7 days following that for the encoded date. Transmission date, with admission, it goes with the discharge assessment, and it's that day 7 following encoded date. All right, so turning to page 214, and me moving the slide forward, let's talk about structure of payment. The standard payment conversion factor covers all operating capital costs, is updated each year, and guess where it's at? The Federal Register, you guessed it. It is wage index adjusted. So let's talk about page 214, looking at figure 8.10. Step 1, you adjust for your geographic factors. Step 2, you adjust for case mix. Step 3, you adjust for policies on qualifying facilities, and that's where you talk about rural locations, share of low-income patients, or teaching facility. Step 4 is payment is determined. And this just goes through that. And notice again, the wage index is different. It was 75.25 for IPPS. It was 66.2 versus 33.8 when we were talking about LTACs. Now we're here at IRFs, and it's 71 versus 29. So watch out for those kinds of itty-bitty little details that we are supposed to know. Yes, there are case mix groups to look at the variations in the use of resources to care for and provide therapy to patients in IRFs. And the groups represent similar functional related patient discharges, and they're looking at impairment, functional capability, age, and comorbidity. At the bottom of page 215, you can see the impairment groups and their codes. And this gives you a sampling of them. So I don't think, oh wait, they go on to the next page. So yeah, you do get all of them. So you have them all in table 8.9. So take a look at that, just so that you're aware of those, so you can see kind of how those work. They're not a DRG, they're a case mix group, but similar in the point of all of this. There are 100 CMGs, 95 are clinical, 5 are administrative. The administrative ones are for short stay cases or expired patients. Notice the interrupted stays. If a patient is discharged, let's say that for whatever reason they need to go back to an acute care hospital and then readmitted to the IRF within 3 days, that is 1 admission. Another example of special circumstances would be transfers. Let's say a patient's in an inpatient rehab facility near where their accident or traumatic event took place, but the family wants them in an IRF closer to them so that they can take care of them. That would be a transfer situation, and that involves a per diem payment. And they do finally give us these rehab impairment categories in table 8.10. We talked about those earlier. So you can take a look at those and just have examples of that. So when you determine the CMG, or sort of like the DRG, you're trying to determine the CMG because we're in inpatient rehab. It's the impairment group code, which is your reason for admission, and your rehab impairment category. Why are they getting rehab? And then together those determine your reimbursement. And then the comorbidity tiers are applied at the CMG level and impact the relative weights. And the book walks you through this on pages 217 and 218. So take a look at those if you're not sure how that works. There are some provisions, and this is on page 219 in your book. Rural location, again, those costs are higher. They tend to have fewer cases and a higher length of stay. So their payment is increased accordingly. And if you're wondering what fiscal year 2020 is, you can go to the Federal Register and find that. All right, low-income patients. This is based on the IPPS DISH ratio. Remember that? Disproportionate share hospital ratio. And that's in the final rule. And final rules are published where? Yes, you got it, in the Federal Register. And that also increases payment if they're in this IPPS, I say DISH, sorry, from my experience, IPPS DISH ratio. Are they a teaching hospital? There are inpatient rehab facilities that are part of residency programs. You think about physiatrists. They need training somewhere. So if they're a teaching hospital, they have additional funds for the indirect costs of providing graduate medical education. I've worked for organizations that have had graduate medical education programs, and it's really interesting, all the regulations that they have to go through to do that. High cost outliers, just like the other prospective payment systems we have been studying and talked about, there is a high cost outlier when the costs for admission exceed the outlier fixed loss threshold amount. And that gives you the information. And again, if you want to find out what fiscal year 2020 is, you can go to the Federal Register. And actually, fiscal year 2021 should have been released October 1st. So you can even find out what it is, because we're now technically in fiscal year 2021 when you're talking about the government. That starts October 1st of each year and goes through September 30th. So we are now in fiscal year 2021 if you were to go out to the Federal Register today and take a look. Payment, wage index adjustment, standard payment conversion factor, multiply adjusted CF by CMG, relative weight, and apply any applicable provisions. And so again, that's pretty much what you're seeing. This information is at the bottom of page 219. And I won't ask you to actually calculate a payment. You just need to understand that there's a formula behind it that involves the wage index, adjusted standard payment, conversion factor, and then you've got the CF by the CMG relative weight. And then, of course, there's always provisions. All right, that's it for inpatient rehab facilities. Nice and short, wasn't it? Thankfully. We have one last one, and it is home health prospective payment system. So hang on, I'll be back with that shortly.